Hello, everyone, and welcome to our webcast, Moving Towards Ending the HIV Epidemic, Strengthening HIV Prevention and Care in the South. This is the final webcast in our series, and we'll be focusing on cisgender women. My name is Ronnie Gravett, and I'm an assistant professor in the Division of Infectious Diseases at the Heersink School of Medicine at the University of Alabama at Birmingham in Birmingham, Alabama. And here are my disclosures.
Hi, everyone. My name is Moran, and I'm an assistant professor in the Division of Infectious Diseases at Emory University School of Medicine in Atlanta, Georgia, and my disclosures are listed below.
So to review our learning objectives, at the completion of this activity, you should be able to discuss HIV risk behaviors that place cisgender women at particular risk for HIV infection. You should also be able to discuss HIV testing and considerations when starting either PrEP or ART among cisgender women. And then also you should be able to select PrEP and ART options according to the guideline recommendations by the Department of Health and Human Services. So we'll start with ending the epidemic. So as many of you are probably aware of the plan Ending the HIV Epidemic, a plan for America, this is the strategy that was developed in combination with the CDC and the Department of Health and Human Services as a strategy to help us stop HIV with a series of goals to meet by the year 2030. And now this plan is based on 4 key pillars or key strategies to help us end HIV. The first of this is to diagnose all people with HIV as soon as possible. We want people to know their status as soon as possible and then link them into care. And that's the second pillar, and that is to treat people with HIV rapidly and effectively to reach sustained viral suppression. The third pillar is prevention, and particularly this focuses on pre-exposure prophylaxis or PrEP, but also includes syringe service programs if this is something that is available in your area. And then the last pillar is the public health response, and that's really to respond quickly to potential HIV outbreaks to get needed prevention and treatment and diagnostic services to people who need them there. For this plan, there are some core indicators to monitor progress. And by the year 2030, our goal is to reduce all new HIV infections by greater than 90%. But in the interim, there are other progress monitors to meet as well, such as reducing new infections by 75%, increasing knowledge of HIV status by 95%, increasing link to care to reach 95%, and then reaching viral suppression at 95%. Additionally, the goal would be also to be increasing PrEP coverage by at least 50% as well. So when we look at the most recent data for HIV surveillance, so this is data that is from the CDC, the HIV surveillance report with data pulled from 2020. And this year there's just over 30,000 new infections, so roughly 30,400 new diagnoses in the year 2020. Now this is about a 17% decline from the year prior, whereas in the years prior from 2015 to 2019, each year there was about a 4 to 5% decline. But in the year 2020, there was a 17% decline. Now, I wish we could all say that this was from our excellent efforts and that we are making great strides. And while it's true that we are making progress and our decline that we're seeing in new diagnoses is happening, the 17% decline is more likely a remnant or artifact of the impact of the COVID-19 pandemic, particularly with access to care and access to HIV testing. But you can see here the trajectories that are mapped out to meet the goals of reducing new diagnoses by 75% by 2025 and reducing new diagnoses by greater than 90% by the year 2030. So we have quite a bit of work to do ahead of us. So when we look at it by region, so in the US, there were 30,403 new diagnoses in the year 2020. The majority of those, over 50%, 52% occurred in the South. And when you look at cisgender in particular, there were 5,439. Again, this is an undercount of most likely of new diagnoses in the US. But again, the South still has the major burden of new diagnoses with 56% of those. And in particular, Black and African-American women are disproportionately affected, accounting for 61% of new diagnoses in 2020 among cisgender women. And you can see the further ethnic and racial breakdowns below, with Hispanics accounting for 13% and white persons accounting for 22%. So what are the factors that are driving the HIV epidemic in cisgender women in the South? Well, in general, when we look at all persons, the general factors that are driving the HIV epidemic in the South are multiple. So one of them is high poverty rates. So approximately a third of all persons in the South live in poverty areas. Persons in the South are still affected by racism. Although it may not be overt in some instances, there are still remnants of institutional, structural, and systemic racism that are affecting the persons of the South. Homophobia and stigma otherwise, particularly related to sex and sexual behaviors, is also significant in the South. Very importantly, there are significant access barriers in how we are able to reach medical care, or how these persons who live in the South are able to reach medical care. Approximately 50% of Americans who do not have health insurance live in the South. In 9 of the 16 states, so the majority of the states in the South have not yet expanded Medicaid. Additionally, there's limited transportation in rural areas. Persons who live far away from their clinics have trouble accessing the care they need by the provider they need to see. Furthermore, there's still high rates of HIV stigma related to HIV itself, but also related to the practices and the behaviors that increase your chances for HIV acquisition. And lastly, mass incarceration is also a significant concern. But when we look at cisgender women in particular, there are some factors that I think are more notable. One of those being intimate partner violence or violence, gender-based violence directly against the cisgender partner, especially notable among Black women. There are some subtle relationship dynamics that are also important to consider when we think about the HIV risk for cisgender women. One of them is negotiating condom use. So condom negotiation is a very challenging skill, and many persons who are at risk for HIV do not feel comfortable, or they don't feel empowered to really ensure condom use. And this can be a really tricky conversation for women to have with their partners. Monogamy is another consideration, and that mutual monogamy is not always the case. And that so a person may think they're in a monogamous relationship, but it may not be mutually monogamous, whether by design or by deceit. So there's also lower rates of PrEP knowledge and access among women in the South as well. So risk factors that place cisgender women at increased risk for HIV. So some of these we've discussed, but again, racism, discrimination, and HIV stigma are all intersecting here. And so a lot of these persons, a lot of these women have intersecting identities based on their gender or based on their race, ethnicity, or perhaps even based on their religion. And all of them intersect and overlap to increase the stigma that they may experience, and that may be a barrier to accessing care appropriately. Risk of exposure, so receptive sex, so whether that's anal or vaginal receptive sex, is more likely to transmit HIV, and so women are more likely to get HIV during vaginal or anal sex than their partner. They may be unaware of partners' risk factors, so they may be unaware of their partner, male partner, and their risk factors for HIV. And again, as we mentioned, intimate partner violence remains a concern, and that women who are exposed to intimate partner violence may be more likely to engage in behaviors or be forced to engage in behaviors such as sex without a condom, or perhaps using substances or drugs with sex. And these, we know, can increase your chances for HIV acquisition. So I'll hand it over to Dr. Moran to discuss HIV screening and testing.
All right, thanks so much. So HIV screening and testing is extremely important, and it's really linked with the way we think about testing for HIV as well. There's biologic synergy between STI exposure and HIV risk. So STIs cause either or both inflammation or ulceration, which will increase a person's susceptibility to HIV. And then there's epidemiologic synergy. So people who have been exposed to an STI may have other risk factors that might put them at risk for HIV acquisition. So whether it's increased risk through sexual behaviors or because they have come in contact with partners who have HIV, they are also experience increased risk for HIV susceptibility. And this is extremely important among women because we're seeing a huge uptick in congenital syphilis. So about 10 years ago, we saw about 300 cases annually of congenital syphilis in this country. As of earlier this year, the preliminary data from 2021, we had over 2,100 cases of congenital syphilis. And you can see that in the map, pretty much throughout the country, there's very few states that haven't reported at least one case. And so as these cases of congenital syphilis rise, this is a marker of increased rates of bacterial STIs among women. So who should be tested for STIs? So basically everyone. So all adults and adolescents should be tested at least once for HIV. And then more frequent testing is suggested for people with risk factors. So sexually active, either gay or heterosexual men, anyone who reports a history of unsafe sex or shares injection drug equipment should be repeatedly tested for HIV. But other STIs, so sexually active women, young women less than 25, and then older women with risk factors should be tested annually for chlamydia and gonorrhea. Pregnant women who are sexually active should be screened during their pregnancy, and that includes a syphilis screen, HIV and hepatitis B screenings, and then additional testing during pregnancy should include chlamydia and gonorrhea screening with repeat testing needed as women are exposed throughout pregnancy. And then for sexually active gay, bisexual, and other men who have sex with men should be screened at least once a year for syphilis, chlamydia, and gonorrhea. And then those who have either multiple or anonymous partners should be screened more frequently on at least a 3 to 6 month interval. And the CDC recommends oropharyngeal and rectal STI screening in men who have sex with men if those are sites of potential exposure. And so, as we mentioned at the outset, HIV screening is an important first step in ending the HIV epidemic. And there are recommendations put out first by the CDC as long ago as 2006 that recommended routine voluntary testing for all patients at least once between ages 13 to 64 in healthcare settings. And this was not based on reported risk factors. So this was all comers. And this testing was recommended to be opt-out testing rather than opt-in. It did not require a separate consent, did not require any pre-test counseling, and then any repeat HIV testing was left to the discretion of the provider based on patient risk. So those were kind of the older CDC guidelines. In 2019, the U.S. Preventive Services Task Force adopted HIV screening guidelines that based on the fact that identification and early treatment of HIV infection is of substantial benefit to reducing the risk of AIDS-related events or deaths. And I would also argue in reducing transmission. And so all adults and adolescents between the ages of 15 and 65 should be screened for HIV, again, at least once. And then those ages can be extended. So younger adolescents and older adults who are at increased risk should also be screened. All pregnant persons, including those who present in labor or at delivery whose HIV status is unknown, should have an HIV test. And then repeat screening is reasonable for persons known to be at increased risk for HIV infection. And I will turn this back over to Dr. Gravett to talk about PrEP.
Thanks, Dr. Moran. So I just want to take this moment to go back to the STI risks and how we know that the model that was showing that that inflammation, that STIs can cause increased inflammation or ulceration, and that can increase your chances of acquiring HIV. It also can be vice versa, that if someone is living with HIV and they have an STI, then their viral load and their genital secretions may be higher and could potentially lead to more chances of transmission. But one thing I just wanted to know, and I'm interested to know if you've had an experience with this, was with bacterial vaginosis, and what do we call that? And is that really an STI? And I think that's a hot debate as to whether or not BV is necessarily truly an STI as we might think about it. But we do know that BV is a dysbiosis. It can cause general inflammation, recruitment of lymphocytes into the flora. So, it kind of, to me at least, seems like it would be a more significant risk factor, or potentially increase your risk for HIV acquisition as a woman or as a person with a vagina who has BV. So I don't, do you do any kind of counseling for your patients about BV, particularly in terms of HIV risk?
So that's a great question. I think there's a lot in there. So yeah, BV is definitely kind of a high inflammatory state. With the dysbiosis in the vaginal microbiome, you certainly get inflammation, that kind of recruitment of lymphocytes into the vaginal tissue, which can put women at higher risk for HIV acquisition if they are exposed. Whether it's an STI, I think, is a different question. There are certainly women who, seem to acquire BV or have symptomatic BV around the same time that they're exposed to other bacterial STIs like chlamydia or gonorrhea. But there are plenty of other women who kind of develop BV kind of seemingly randomly, or whether they've been treated recently with antibiotics or had other exposures. And so I don't think we can necessarily consider it an STI, although there is a link between sex and BV. As far as counseling, I think in women who have kind of recurrent BV, I do think that's an important conversation to have with women if they are sexually active, and especially in those with multiple sex partners or sex partners whose HIV status is unknown, that letting them know that, BV may put them at greater risk of HIV acquisition, and to consider other preventive measures such as obviously condom use, but also that might be a good candidate for PrEP.
Great. Yeah, really helpful information. Thank you for sharing that. So speaking of PrEP, we'll move right into our next session, which is looking at PrEP in particular. And I do note that we have a question in the chat, and hopefully I'll be able to answer these questions with some of the content we'll discuss. So PrEP, there is a tremendous PrEP gap in the United States. We know that 1.2 million Americans are likely to benefit from PrEP, whether that's because they're a man who has sex with men, they're persons who inject drugs, or they're a heterosexual person with increased chances of HIV acquisition. And when we look at MSM in particular, we know that there is a large proportion that are aware, but far fewer are likely to use PrEP. So if we think about people with an indication for PrEP, at least in the year 2020, 75% go without PrEP. And so we know that a lot of people, especially cisgender women, need PrEP, but they're not able to get PrEP for various reasons. And so when we look at just as a metric of how we measure PrEP need, so there's this really great tool, the PrEP to need ratio through AIDSview with some colleagues at Emory who've developed this. And basically the idea is a higher number means there are more PrEP prescriptions per new diagnosis of HIV. So the higher the number, the better. That means more people are being protected by PrEP than the number of people who are acquiring HIV. So if you look at this map of the US, the darker the color is, the redder the color is lower, which is what we don't want. So if you look in the South, all of the states of the South have a very low PrEP to need ratio. So this really indicates there's a very high need for PrEP in the US, but particularly among cisgender women throughout the US and notably in the South as well. So some key barriers to PrEP uptake and potential approaches to removing these barriers. One of them is awareness of PrEP. And so patient and provider education is very important. Providers need to understand that PrEP is not just something for gay men. It's not just something for what they might consider promiscuous persons. They really need to recognize that PrEP may be for a lot more people. And in fact, it is. And so the most recent CDC guidance really doesn't say, it kind of removes the stipulations around PrEP. It should be, do you have an increased chance of risk for HIV? If so, basically you need PrEP. But if any person is sexually active, then the provider should discuss PrEP with them. And if the person or the patient asks about PrEP, then the provider should provide it. There's really not any place in the new CDC guidance that says no. So HIV risk perception is another common barrier, and that people may not understand or recognize their risk for HIV. And so when we think about some of the barriers or some of the risks for HIV among cisgender women, some of them are that they are not aware of their partner's risk factors. So they may say, no, I am monogamous only with my one partner, but their partner may not be monogamous. And then within that coupling, they may or may not use barrier protection. They may not use condoms, whether male or female condoms, which we know would also reduce their risk for HIV. Stigma is still a significant barrier, particularly around how we discuss sex in the context of Is it healthy? Is it safe? How is the provider taking a sexual history? But also, is the patient or is the person comfortable coming to the provider having those conversations? So care really needs to be provided in a culturally humble way, meaning you are having these discussions that are important, but in a very respectful way, coming from them, approaching their education and advocacy in a way that is appropriate for that person. There may be provider bias and distrust of the healthcare system. So this is particularly notable with intersecting identities related to race, ethnicity, or socioeconomic status, or also LGBTQ status or identity. Access to Medicare, this is a very significant barrier that is a little bit more difficult to move the needle. There are policies in place, and sometimes it's often hard to change policies, such as expanding Medicaid. But access to medical care is a significant barrier, whether they're able to physically access a clinic or reach transportation to get them there, or they may not be aware of PrEP providers. And so it's important that we think about how can we provide PrEP and where should we provide PrEP. So very often PrEP is siloed along with STIs or sexual health or HIV care. And it doesn't have to be that way. PrEP can be provided by primary care doctors. It can be provided by obstetricians, gynecologists, family care. It should be provided by pediatricians to adolescents and other persons, younger persons who are at risk for HIV. But it also should maybe be expanded into substance use clinics. So whether that's medication assistance clinics, buprenorphine clinics, or methadone clinics are other ways of getting PrEP to people who may need it. There's competing priorities. So folks may be too busy going to work and trying to get a paycheck and make a living wage for them to be able to focus or think about their HIV risk and PrEP. But also some of the more particular or some of the more idiosyncratic issues are things like side effects to the medications, issues with taking the medications. So when we think about PrEP service delivery in Black cisgender women in the South and what they prefer, this is work done by Dr. Letitia Lopre, and this is a survey among cisgender women in Alabama without HIV who were living in both either an urban or a rural setting. So about 2/3 of these women in the study were in an urban area. And about 30% of them were willing to use PrEP, 35% said no, and 35% said they wasn't really sure. But what they really noticed, some of the big takeaways from this were that the willingness to use PrEP, the difference from others were that these women who were willing to use PrEP are often younger. They may have had lower religiosity. They may have had experienced less discrimination. They may know more about HIV and have a higher perceived need for PrEP and preventing themselves. And they also may be more sexually active. So future research in this area should investigate strategies to implement PrEP around service delivery programs for Black cisgender women that can be coupled with routine gynecologic care that provides non-oral formulations or long-acting oral formulations. So either that's a long-acting injectable or a long-acting oral. Online services in rural areas especially, so if they're not able to reach their clinic, they may be able to access telemedicine options, but also community engagement and hearing PrEP service delivery and PrEP strategies through the community is also another way of increasing uptake among this population. So there are also some socio-structural influences among Black cisgender women in the South. And so these were found with focus groups conducted in Jackson, Mississippi for PrEP-eligible women who actually never started PrEP. And some of the concerns that were identified during these focus groups were that there was lower PrEP awareness, meaning that many of these women weren't aware of PrEP, or they didn't know that they were at increased risk for HIV particularly, so they were not interested in PrEP. They were concerned about side effects. There was concerns about costs. There's limited marketing. There's limited outreach to cisgender women about PrEP. A lot of PrEP media is focused on LGBTQ persons, and while that is very important because those persons have increased chances, we also should be mindful to ensure that appropriate outreach to cisgender women as well. So some of the facilitators or some of the ways that promoted PrEP delivery were women's empowerment and advocacy. So ensuring that women have agency over their sexual health and sexual health decisions is very important in helping them to start taking PrEP. There is a need for increased PrEP-specific education, as well as positive influence from other women who have used PrEP previously. So knowing somebody that was on PrEP, a woman that was already on PrEP, would help another woman perhaps start PrEP. So with the new updated guidelines for HIV prevention in the US from the CDC, some of the important factors that are new are for starting and restarting PrEP, there needs to be an HIV antigen test, antibody test. So that's not necessarily new, but what is new is for the addition of injectable PrEP, that viral loads should also be included for PrEP provision if they're getting injectable medicine. So if they're on PrEP or recently took PrEP, they should have an antigen antibody test as well as an HIV RNA test. The reason for this is because it's theoretically possible that if they acquired HIV while on PrEP, that the PrEP medicine would be enough to suppress their viral load. It may not be enough to keep it suppressed and maintain viral suppression, but enough at least to kind of trick the antigen antibody test. So what happens is if you have kind of a low level viremia, your seroconversion or your time to having a positive fourth generation test may be lower. And therefore, if you do an HIV RNA test, you'll be able to detect the lower levels of viremia that you might otherwise miss. As I mentioned earlier, PrEP should be offered to all sexually active adults and adolescents who are at risk for HIV. And importantly, the conversation should be had. So if you, as a provider, know that your patient is sexually active, you should know because you should ask them, then you should have the conversation about PrEP. And if they ask for PrEP, then you should never say no. So there are two options available. So there's two oral options, both tenofovir-based compounds, both combination therapies. So one is tenofovir disoproxil fumarate combined with emtricitabine. That's the F/TDF. So that is FDA approved for all persons regardless of sex assigned at birth, as long as they are adults and adolescents weighing at least 35 kilos. The FTAF is tenofovir alafenamide. That is a newer version of PrEP, FDA approved in 2019. That is not FDA approved for vaginal exposures. And so that's a key point, is that there's only one oral option available for women or for persons with vaginas or who are at risk through vaginal exposures. But importantly, we do have a new injectable option with cabotegravir. And so this has really moved the HIV prevention space forward and leaps and bounds. So this is a really incredible advancement in our space. So just to quickly review some of the risk factors for HIV. So, the indications for PrEP. Sexually active adults and adolescents who have anal or vaginal sex in the past 6 months, plus they have a sexually active partner with HIV. I would say really that's for persons who have an unknown viral load status or they're not linked to care, especially. Now, certainly it's okay if they're in a serodifferent relationship that the person who's HIV negative be on care, but it's particularly important for those who are in a relationship and the person living with HIV is not virally suppressed. If they've had a bacterial STI in the last 6 months, or they have a history of inconsistent or no condom use with their sexual partners. And then otherwise for exposures through injection drug use, so they either have a partner with HIV or they share injection and drug equipment. And I also take this moment just to think about what do we qualify as injection drug use. So very often we think about substance use, whether that's heroin or methamphetamine. But it's also important to note that sometimes injection equipment that is shared may be things like botulinum toxin or Botox. It may be cosmetic fillers. It may be hormone therapy for persons who are transgender. So there are other things, other medicines that may be injected and shared. So when you have a conversation with your parent about, or with your patient about injecting drugs, it's important to be mindful that it may be more than just illicit substances. So this is a table showing your currently available PrEP options, particularly our oral PrEP options. They are all really FDA approved for daily use. There is a non-FDA approved strategy for non-daily dosing, but that really should only be done for MSM, and we'll talk about that briefly why. But that's a strategy using 2-on-1 or 2 pills before sex, and then 1 pill after a day after, and then 1 pill another day after. But for cisgender women, there's really the major option available is tenofovir disoproxil. So that's 200, 300 milligrams taken daily. Daily FTAF or TAF is not currently FDA approved for non-vaginal exposures. So in general, oral PrEP clinical eligibility means you have to have a negative HIV test, and it has to be documented, ideally within 1 week before starting PrEP. No signs or symptoms of acute HIV infection. An estimated creatinine clearance of 30. However, this for cisgender women, for oral tenofovir TDF PrEP, it really needs to be greater than 60. So 60 is the GFR cutoff for tenofovir disoproxil, which is what is approved in women. The tenofovir alafenamide goes down to 30, but in this case, it should really be 60. And then no other contraindicated medications. So daily oral PrEP efficacy and medication adherence. So the most important factor about having effective PrEP is that you take your PrEP. If medication adherence is critical to achieve your maximum HIV prevention benefit and reduce the risk of developing drug resistance if HIV acquisition were to occur. There's really not as much wiggle room among cisgender women or among persons with a cervix or vagina in terms of missing doses. So daily oral PrEP provides greater than 99% for rectal exposures and around 94% for vaginal exposures if taken as directed. And so we'll talk about what does it mean and what amounts of adherence really must be achieved to have that adequate protection. So there's some key components to oral medication counseling and provide simple explanations and education, support their adherence, and monitor medication in a really non-judgmental way. So not asking them like, hey, you haven't missed any doses or anything. You really want to approach that from how are you doing with your PrEP? How is it going for you? Is it working for me? Tell me about your doses. Have you been missing any? You kind of really want to ease into that conversation and not be outright accusatory in how you assess that. So when we think about medication adherence among cisgender women, the clinical trial data really shows that there are, for vaginal tract, for cervical vaginal tissues, you really need 6 to 7 doses per week to maintain that protection. For colorectal tissues, 2 doses per week. There's modeling data that really says for MSM and rectal exposures, you need at least 4 doses per week to reach protection. But for cisgender women and other persons with cervical vaginal tissues, it really is a 6 to 7 doses per week. So that means taking it every day, rarely missing a dose. Importantly, it's also, we should note that it takes a lot longer to develop adequately protective tissue levels in cervical vaginal tissues. So for rectal exposures, for MSM in particular, it may take 7 days to reach a protective level. For cisgender women and other persons with vaginas, it takes up to 20 days, or really takes 20 days to achieve that protective level. So it's important that they take every day for 20 days to reach that protection level and then continue to take the medication daily. There's all kind of reasons that they think may go into this. So this is a model, a conceptual model about how we think in terms of what are the factors affecting the tissue levels? And it may be menstruation, it may be menopause, contraception, and HRT, so the hormonal effects of it, but also is there issues with inflammation? So as we talked about earlier, is there disruption of the microbiome causing inflammation or other co-infections of STIs? But also there's some thoughts about how the lymphocytes are deposited or in that area as to how they're able to get, how the medicine is able to get to target lymphocytes in the tissues. So when we think about the protective levels for tenofovir trough concentrations to prevent HIV, it's a much lower dose for men as compared to women. But again, that may be influenced by multiple factors, but probably the most important point to consider is that it has to do with where the tissues are. So injectable cabotegravir for PrEP, I do see we have a question in the chat. Does your practice offer injectable PrEP? And if so, what are some of the lessons learned incorporating injectable PrEP into your practice? We'll talk about that briefly. That is a much more complicated question than I think may be easily answered in this, but we'll certainly talk about that briefly. So injectable cabotegravir for PrEP. So this was FDA approved in 2021, late 2021, and this is really a game changer. This was a non-oral formulation. This is an injectable medicine that is given as a long-term injectable that is highly effective at preventing HIV. So some of the important important factors to consider for HIV, for using cabotegravir for PrEP is that you must have a documented negative HIV antigen antibody test, and importantly, also exclude acute HIV infection using an RNA assay. The reason for this is in some of the HIV acquisitions that occurred and the trials that supported this approval, they did see early infections that were missed because of the viral suppression caused by the cabotegravir, that they saw delayed seroconversion. And for injectable PrEP, they saw delayed seroconversion by up to 90 days. So when they looked at the stored specimens from time of site positive, meaning the time they had a positive fourth generation test, when they went back, they actually saw detectable HIV RNA as on average roughly 90 days before then, yet in the interim, they did not have a positive fourth generation test. So that's why the HIV RNA quant is so important to begin with. Of course, no signs or symptoms of acute HIV either. So this is FDA approved regardless of sex assigned at birth. So this is really important because this is another option for cisgender women, as well as adolescents who are at least 35 kilograms. So it's dosed as you can have an oral lead-in. It's not required. That's really to assess tolerance, and it's 30 milligrams per day. But it really starts with an initial dose, 600 milligrams given in either the left or right buttock, and then a second dose 4 weeks after, and then every dose after that is every 8 weeks. And so it's the same dose, 600 milligrams at each administration. So there's two supporting studies that really support this, and they're both very, very similar. So HBTN 083 and 084, they were both double-blind, double-dummy clinical trials. So what that means is that every person in the trial got an active PrEP agent, whether that was injectable or oral. So every person took a pill and also got an injection, but they don't know, you're blinded as to whether or not your pill is active or whether or not your injection is active. So the pill was oral tenofovir PrEP, the injection was cabotegravir. So persons who were in the injection arm got a placebo pill and then a cabotegravir injection, and the other arm, they got daily oral PrEP and then placebo injection. And so this is the data from the 083, 084. On the left is the MSM and transgender trial, which showed a hazard ratio of 0.34, so roughly a 66% risk reduction compared to daily oral PrEP. But I think more impressively, the 084 data for cisgender women showed a risk reduction of about 88%. So compared to daily oral PrEP. So they only saw 4 HIV acquisitions in the cabotegravir in the blinded phase. So that is a considerable risk reduction. And this is compared to daily oral PrEP. So clearly, cabotegravir meets the criteria for superiority. And in fact, it may be, it's likely that the hazard ratio is actually lower because accounting for one of those infections may have been a baseline infection. And when they extended this into the unblinded analysis, they again saw the same, roughly the same hazard ratio hold out. So some of the important considerations on the impact of long-acting cabotegravir on detecting HIV infection. So we alluded to this a little bit earlier, and that cabotegravir can suppress viral replication. It can suppress the RNA and delay the time to antibody seroconversion. So sometimes rapid tests and antigen antibody tests may not detect an actual antibody, even though there is HIV present, because the seroconversion has been delayed. So supplemental antibody tests may be negative or indeterminate for many months, as we discussed, upwards of 90 days in some cases. That's why it's important to check an HIV RNA level. So HIV RNA levels may remain low or undetectable for long periods. Cabotegravir is a very effective medicine. It's an integrase strand transfer inhibitor, so we know it's highly effective at reducing HIV RNA levels. But some important impacts for delayed detection of HIV. There's an impact on personal health. So the person there's a delay to starting them on HIV therapy. There's potential ongoing HIV transmission, although it's really hard to quantify that, particularly for people if they have low levels of HIV viremia. How transmissible are they? We don't know, but it's potentially transmissible. And then importantly, the emergence of INSTI or integrase strand transfer inhibitor resistance with potential compromise to our first-line therapies, which are integrase inhibitors. Dr. Moran will discuss that further. So I'll go back and just briefly mention some practice, some important. injectable PrEP is very challenging. It is something that requires a little bit of investment in by the clinic. So I would recommend, discussing with the manufacturer has, and this is only for US based clinics and providers. So offers an assistance program where they can help navigate the insurance. And so the insurance is one of the biggest challenges here, because insurances may cover this medication through medication benefit, or they may cover it through pharmacy benefit, or they may not cover it. And so that's probably the trickier part about navigating how the medication will be covered. If it is a medication benefit and the clinic is required to what we call buy and bill, it could be a pretty hefty cost and investment by the clinic initially. Pharmacy benefit, less impact on the clinic itself to acquire the medicine. But there's also impacts on staffing, because all of these injections must be administered by healthcare personnel in a healthcare setting. So this is a person who you may have to pull from other duties to do this. And other things to think about are getting HIV RNA testing. And so that may not be something that many clinics are able to do readily, or there may be a longer turnaround time. And it's okay if there's a longer turnaround time, as long as you're getting that 4th generation test at the same time. And you can always follow up with the RNA afterwards. So for same-day PrEP prescribing, it's very similar to oral PrEP. There's just some important caveats, and I'll just discuss when it is appropriate to not use same-day starts. So if they're not sure they want to start PrEP, then you don't need to start them on the same day. If you're unable to do blood draws or for laboratory testing, particularly for the HIV test, then they should not have same-day start. If they have any concerns about acute HIV, then you should not be able to, you should not provide PrEP same day. They have a history of significant renal disease or other issues where you're not sure about the renal function, then it would be better to check their creatinine and renal function before pursuing this. And if there's issues with medication, that may delay it as well. But probably the most important facet of providing same-day PrEP is you really need to be able to contact the patient. You really need to have great contact information. So on your initial lab work, which is the same as what you would collect regardless of when you start PrEP, all those labs, if there's anything abnormal, you need to be able to reach the patient to have them come back in. Because the idea with same-day PrEP is they get the medication, they start taking it that day, regardless of the test results. Now, ideally, they should have a rapid point-of-care HIV test at that time. And if that's negative, then you can give them a PrEP prescription. But you really need to be able to get quick lab result turnarounds and be able to contact the patient if there's any abnormal lab values, if we need to make any changes. So briefly discuss lenacapavir. So this is an investigational agent. It's a long-acting injectable studied through the PURPOSE 1 and PURPOSE 2 trial. So these would be subcutaneous injections, not necessarily intramuscular, which is cabotegravir. Cabotegravir is intramuscular injections. So these trials are underway, and we're hopeful that we may have another successful non-oral PrEP formulation. And I'll speak very briefly about the dapivirine ring, particularly because the manufacturers of this product have withdrawn their new drug request, their IND for this medication. So, but this is now now approved in Southern Africa. It is a monthly vaginal ring that is formulated with dapivirine, and we did see some modest, maybe not as significant as risk reduction as with cabotegravir, but still some risk reduction with this, and reduction in HIV infection in the dapivirine arm, about 31%. So this is this is not an oral medication. This is not an injection. It's a vaginal ring. Importantly, one of the most interesting parts is that it can be potentially co-formulated with contraception. And so here's just some more data supporting the use of the vaginal rings. This is the tenofovir vaginal ring. Currently not in practice. This was included in some vaginal tenofovir gel was included in some earlier PrEP studies. This is with a vaginal ring. And really the promise in these agents is that if you can co-formulate contraception with HIV prevention modalities. All right, and I'll hand it back to Dr. Moran for linkage to care and treatment considerations.
All right, thank you so much, Dr. Gravett. That was a wonderful discussion on PrEP, and I am really excited. I agree that the injectables, I think, will be a game changer, especially, lenacapavir is every 6 months. It's really kind of amazing. There was a question that just popped up in the chat, and I don't know if we have a ton of time to address all of these issues today, but with the recent decision in Texas regarding PrEP, which is another barrier, it is likely other states in the South will adopt this ruling. What is the best dialogue to use to ease the panic in patients who believe their access to PrEP will be affected? And I'm also wondering if you've come across any of these issues in your practice too.
Yeah, so that's a great question. That's a hard question. So the ruling in Texas is very disappointing. I think we are all we are all very pragmatic about our approach to PrEP, and we want to make it as easy as possible for our patients to be on PrEP. So when policy changes happen that potentially impact their care, it's very concerning for many people. And so, I practice in Alabama, so this is a topic of conversation that has come up. So when we think about best dialogue, so first of all, it's important to note that the ruling really just eliminated the employer's requirement to cover PrEP for zero cost sharing. So that's a particular caveat related to PrEP in the ACA, and that since PrEP has a grade A recommendation from the USPSTF, it should theoretically be covered without cost sharing. So the same thing for other highly effective prevention modalities. So, I talk to my patients about this, that this is not necessarily the government saying that insurance will not cover PrEP anymore. It's more so that the employer may not allow it in their plan. So, it's very likely that their insurance companies will continue to cover PrEP, but at the zero cost sharing, that's a little bit more tough to navigate. I think it'd be very interesting to see how this plays out, and particularly with appeals, because there was some other language in that ruling that went beyond PrEP and just to the ACA requiring no cost sharing for other prevention. So there's potentially far-reaching impacts from this decision.
Yeah, thanks for that. I think there's a lot more to come there. I want to shift gears a little bit from HIV prevention to HIV linkage and treatment. This is a schematic looking at the cascade of care, the continuum of care in the US from diagnosis of HIV to linkage of care within a month. The goal, again, in the EHE, or the ending the HIV epidemic, is 95% to actual receipt of care after that person is linked, and then ultimately achieving viral suppression within 6 months. And you can see there are step-offs at every step along the way. And this graph is broken down by gender identity. And there really aren't many differences between cis men, cis women, transgender men, any additional gender identities. We pretty much see about 60 to 65%, maybe a little higher in some groups, of people achieving viral suppression within 6 months. And there's a lot of reasons for this step off. But for the purposes of this talk, we're going to get into ART and what ART is recommended and recommended to start. So even in the past several years, it's actually gotten much easier to remember what to start people on and to start people on antiretroviral therapy. So recommended in both the Department of Health and Human Services recommendations as well as the IAS USA guidelines are all of the regimens contain integrase strand transfer inhibitors, so either bictegravir, emtricitabine, and TAF, or a dolutegravir-based formulation. In the DHHS guidelines, that includes abacavir and lamivudine, only if the person has a negative HLA-B5701 and does not have chronic hepatitis B infection. You can also include dolutegravir plus either emtricitabine tenofovir alafenamide or emtricitabine tenofovir disoproxil fumarate. Just those regimens include 2 tablets, still once a day, but they do include 2 tablets, which may be tricky for some folks. And then the third regimen that is recommended as first line is dolutegravir lamivudine. So this is a 2-drug regimen that's a tenofovir sparing regimen, which may be important for patients with renal disease or other intolerance to tenofovir. The caveats there are, again, no hepatitis B and a pretreatment viral load less than 500,000 copies, and no known resistance to lamivudine. There are side effects and metabolic risk factors that come into antiretroviral therapy, and there have been from the beginning. And I will say that in the current era, ART is much safer, and there are way fewer risk factors or kind of side effects than we used to experience. However, one of the side effects that has consistently played out, especially in people who are on integrase strand transfer inhibitor and C-containing regimens, is weight gain. Now, most people, when they start antiretroviral therapy, do gain weight. And for some, this is a return to health. So it is after starting ART, and when you don't have a circulating HIV viral load anymore, you have reduced resting energy requirements, you have an improved appetite and nutrient absorption, and all of these result in really a healthy weight gain. There can also be impaired energy storage in the sub-Q fat and altered lipid kinetics. And then other issues such as access to nutrition and smoking cessation play a role, as well as specific ART regimens. These are associated with some comorbid conditions, including insulin resistance and diabetes, dyslipidemias, liver fibrosis, hypertension, coronary and peripheral arterial disease, frailty, which includes sarcopenic obesity, and neurocognitive decline. All that is to say, while these side effects are real and they do exist, taking ART is infinitely better for your health than not taking ART, despite some of these side effects. There are several drivers of weight gain in people with HIV after they initiate antiretroviral therapy. So first is that return to health phenomenon, and this is particularly true in people who have started ART when they have advanced HIV with a low CD4 count and a high viral load. Specific ART, including our second generation INSTIs, dolutegravir and bictegravir, as well as the tenofovir alafenamide formulation, are associated with weight gain. Protease inhibitors to a lesser extent, and then the tenofovir disoproxil fumarate TDF formulation and efavirenz and an RTI are actually associated with some weight loss at ART initiation. And what's especially pertinent to this discussion is that women and people who identify as Black are actually more likely to gain weight after initiating ART for reasons that we haven't fully worked out yet. This is a study that looked at basically all of the randomized controlled trials initiation of ART for the past 15 years or so, and broke down weight gain by sex, by race and sex, by ART type. And what they found is that women, and Black women in particular, gain more weight after starting antiretroviral therapy. People who start INSTIs gain more weight than people who start protease inhibitors or NNRTIs. And among the NRTIs, people who start on TAF gain the most weight, followed by those who start abacavir, and then followed by those who start TDF, compared with those who start on zidovudine or AZT. And so again, for many people with HIV, gaining weight after ART is not necessarily a bad thing and is really part of a return to health. However, some ARV regimens are associated with greater weight gain than others, which suggests that these drugs themselves play some role in contributing to weight gain. NC-containing regimens, particularly the second generation NCs, bictegravir and dolutegravir, have been associated with greater weight gain than other types of regimens. And this weight gain and a higher BMI on ART is accompanied by an increased risk of metabolic syndrome, hypertension, other weight-related conditions. So monitoring weight and metabolic health after ART initiation can actually identify people with HIV who may need lifestyle changes or pharmacologic intervention to control their weight gain. An important caveat here actually is in pregnant women. And when pregnant women are started on ART, pregnant women started on dolutegravir do gain more weight than pregnant women who are started on efavirenz, but it's actually a healthy weight that they gain weight that they're supposed to gain during their pregnancy, whereas women on other regimens were not actually gaining enough weight during their pregnancy. And whether this translates ultimately into a lower incidence of low birth weight babies and other pregnancy complications remains to be seen. But this is one special population where the INSTI-related weight gain may actually be of some benefit. So I'd like to wrap up this session by talking about HPV-related disease. So when speaking about women's health, we really can't get away from talking about cervical cancer screening. And this is one area where we have actually pretty good guidance from the ACPE. And that screening for cervical cancer is actually a little different in women with HIV compared to those without. So similar to the guidance in the general population, screening should start within 1 year of sexual activity and no later than age 21. For women ages 21 to 29 who are living with HIV, they should have a PAP at the time of their HIV diagnosis. That pap smear should be repeated yearly for 3 times. And then if all PAPs are normal, they can go out to a pap smear every 3 years. Again, in the same age group, so age less than 30, HPV testing is not indicated unless there are abnormalities found on the pap test. And that's really because HIV is very highly prevalent in that age group, and HPV kind of comes and goes, and a lot of women, especially younger women in their 20s, will acquire HPV and then clear it. And so testing for it doesn't necessarily change any outcomes. Now, for women who are 30 and older, the screening guidelines are really similar to those ages 21 to 29, except you include HPV co-testing. And so, if you're only going to do a PAP only, it should be the same as 21 to 29 years. If you include HPV co-testing, if both are negative, both the PAP and the HPV, then you can go out to co-testing PAP with HPV every 3 years. This is different from the guidelines for the general population, which will say that if you do co-testing in women 30 and older, and it's negative, you can go out to every 5 years. There is no guidance that you can extend cervical cancer screening out to 5 years in women with HIV. And in general, screening should continue past 65 years if that is within reason, and if the patient has kind of a reasonable life expectancy and doesn't have a lot of other comorbidities. There is no guidance in women with HIV to stop pap smears or to stop cervical cancer screening after 65 years. But again, that includes just a conversation and a risk-benefit conversation with your patient. And then how to deal with abnormal PAPs or HPV, the follow-up is very similar to the general population. So anything higher than an ASCUS with a positive HPV or an ELSO with a negative HPV, you can just repeat co-testing in a year. And then anything that is ELSO with positive HPV or greater would go to colposcopy. And, something I think that gets missed when we talk about HPV disease in women is anal intercourse in women. And so this was an observational study of the WISE, which is the Women's Interagency HIV Study. And this is a study of women living with and women who are at risk for HIV that has sites throughout the US, including 4 different sites in the South. And data are collected every 6 months. And the median follow-up in this study was over 14 years. And the women included in the study were the HIV negative women, were the women who were at risk for HIV acquisition but did not acquire HIV. 94% of these women reported having a male sex partner. A third of these women reported having any anal intercourse at any visit, and the proportion did decrease with age. And consistent condom use was actually quite low. And so I think this is sometimes something we forget or sometimes neglect when we're doing cancer screening in women, that it also includes anal cancer screening in patients who are at risk or who have engaged in anal intercourse. And then finally, I'll mention the ANCHOR study, which was published earlier this year, that looked at what happens after you screen people for anal cancer. So this isn't telling you exactly who to screen for anal cancer, but this is to tell you what to do with the results. And so this was a randomized 5-year prospective trial in the US conducted between 2014 and 2021. They enrolled just under 4,500 participants, and they included people with HIV who were 35 years and older who had biopsy-proven anal HSIL. 15% of the study cohort was women. And the study arms included active monitoring versus treatment of HSIL. And the objective was to determine the incidence or whether treatment prevented progression to anal cancer. And so basically the answer is yes, the study was stopped early because there was a significantly decreased risk of progression to cancer in the treatment arm compared with the active monitoring arm. And so the risk reduction was about 57%. There were 9 cases versus 21 cases over a median follow-up time of just over 2 years. And so this was a statistically significant finding. And again, just points to the importance of actually screening for anal cancer in the right population. And I will turn this back over to Dr. Gravett to wrap us up.
Thank you, Dr. Moran. Very insightful information about treatment and for HPV-related disease. So with that, I'd like to conclude our talk. And I hope that throughout this talk, you've been able to learn something about either prevention or about treatment, understanding that both are very important, that both sides to the HIV care continuum, a status neutral approach is needed to really help us in the HIV epidemic. So with that, we have concluded. I'm happy to stay on and take any questions if there are any extras, but thank you all for your attention.
I think I did see another question. What are some of the barriers that keep cisgender women in your practice on PrEP?
It's a good question. I think, when we think about what keeps women in PrEP, we have to kind of take a step back and think about what keeps them out of PrEP and how do we navigate those barriers. So things like, of course, awareness and risk perception that we've talked about. So we have to make sure that these persons know they have their HIV risk, and we have to have an honest conversation with them about their risk. So some of the things we talked about are not being in mutually monogamous relationships or inconsistent condom use as being particular risk factors for HIV transmission among cisgender women. So when we have that conversation with them, a lot of women will like, well, I'm faithful. I know he's faithful. And that is a tenuous conversation to have. But it's important just to empower them. It's like, well, if you have any doubts or you think otherwise, PrEP is still for you. So ongoing affirmation of their sexual health, I think, is very important. Other things to help kind of remove structural barriers and thinking even further than that, things to help, and this might apply to other people, but what are the competing priorities? If they have to work during the day, are you able to have a clinic in the evening? Are you able to have a weekend clinic? What are the telemedicine options that you're able to offer? Are they able to access transportation to your clinic? Are you in some way able to facilitate transportation to your clinic? I think those are some of the things that can really apply to all populations who need PrEP. But when we think about cisgender women in particular, I think it's important to continue to have conversations about their risk perception awareness. I think it's also important to have peer navigators who are also cisgender women. So having women who have been successful with PrEP and who've done well with PrEP, I think can also be very helpful to help retain other cisgender women in PrEP care. So, I mean, that could be a topic in and of itself, and that's a really important matter. Certainly, we don't know enough about. But I hope that answers the question at least a little bit. Okay. Well, I guess seeing as there's no further questions, thank you all for your time. Thank you all so much for your attention. Please feel free to reach out to us with any questions or other concerns. Thank you all.